yeah, you just totally forget.
Right, yeah.
But I think she...
Good morning, good afternoon, or good evening to our audience around the globe, and thank you for joining us today. My name is Shipra Srihari. I'm a resource tracking specialist on the Health Finance and Governance Project, and I will be serving as the moderator for today's webinar. Thank you all for joining us. This is the third and final of 3 webinars hosted by the HFG project that focus on health expenditure tracking. This webinar is being hosted in collaboration with the Health Financing Subgroup of the Health Data Collaborative Technical Working Group on Health Systems Monitoring. You may have tuned in to the first webinar in our series, which focused on using health expenditure data for policy reform. That was earlier this year, and just back in May, we had our second webinar, which discussed the factors involved in selecting the right tool to estimate health expenditure in a given country context. Today, our final webinar is geared towards an audience that could benefit from some lessons learned on the production of health expenditure estimates. So today, what we're going to discuss is streamlining the production of health expenditure data. In other words, how can we make the process of producing health expenditures more efficient so that countries can conduct regular expenditure tracking exercises? We hope that you'll be able to apply some of these strategies in your country work. USAID has invested in expenditure tracking for many years, supporting the production of health expenditure estimates in collaboration with a number of partners, including the World Health Organization, the Gates Foundation, Gavi, the Vaccine Alliance, OECD, and others. During the tracking exercises supported by the HFG project and its predecessor projects, our aim has always been to build capacities in countries in which we work and to institutionalize the process for producing health expenditure estimates. What we've seen repeatedly in our work is that countries often grapple with the time and the resources needed to do expenditure tracking. So that is the focus of our webinar today. So to start off, we're just going to go through some logistics quickly and do a poll of our audience. We'll then have an interview of our 3 expert panelists from HFG, the government of Benin, and from the World Health Organization, and then we'll wrap up with a question and answer session where you will have a chance to ask questions of our expert panelists. So the WebEx platform, as you may already know, has a couple interactive features, Q&A and chat. You'll see the buttons for these features in the right-hand corner of your WebEx window if you dialed in using your computer. You can use the question and answer feature to ask questions of our panelists throughout the webinar that we will compile and ask during the question and answer session at the end. Make sure that if you do submit a question, you submit it to all panelists, and also please specify if your question is for a specific panelist. The chat panel is used to interact with fellow participants, or in case you're experiencing any technical problems, you can send a chat to Alina Sims. Please note that this webinar is being recorded and will be available soon after today on the HFG website. So let's start with our poll question to understand what you, our audience, feels are the types of health expenditure data that are most difficult to collect. You'll see a pop-up on the right-hand side of your screen. Please select which of these types of data apply to you in terms of difficulty in collection. You can select as many as apply, and after you've selected your responses, make sure you scroll down and click Submit. So we're just waiting on our poll results. So it looks like household data seems to be what 18% of our respondents indicated is the most difficult to collect. And a few of you also mentioned that government and donor data have been difficult, with just one or two mentioning the other types. So it's good to have a bit of an understanding. Hopefully some of the issues that we've addressed today during the webinar will help you all in your expenditure tracking exercises in country. So let's turn to our first panelist now, Mr. Tefai Ashagari, who is going to share with us, based on HFG's extensive experience in expenditure tracking, some strategies that you can use for streamlining production of expenditure tracking data. Tefai has 15 years of experience in the health sector. His expertise is in health finance and related issues, including health finance policy research. He has developed policy and legal frameworks for implementing health finance reform. He's organized and coordinated policy dialogues and consultations, helped build capacity for healthcare financing reform, and he has led research tracking exercises, costing, and analysis. Tefai, thank you for joining us today, and welcome. Could you please start by telling us about the key factors that you think are important to simplify and streamline the production of health expenditure data?
Thank you, Shipra. Good day, everybody. I know, depending on where you are, it might be evening, and thank you for joining us for this webinar and discussion. So back to your question, Shipra, there are three main factors that I think of that play a role in any resource tracking exercise when it comes to streamlining. I use resource tracking broadly, although we are talking about health expenditure tracking for this session. These three factors are related to what extent do we have the needed data readily available, and do we know about them? And those are some of the things that I would think would be important. The second is, oftentimes there is different stakeholder that is trying to track either a subset or a component of the expenditure, the health expenditure. So to what extent are these coordinated, have a bearing on the for a streamlined process? And the third, but not least, very important, is the level of stakeholder engagement.
Could you elaborate, Tefai, on these factors based on lessons learned by the HFG project?
Thank you. So, as was alluded to in the initial poll, any resource tracking exercise that we have in the health sector are going to capture either all or a subset of spending on government, households, insurances, or development partners and NGOs. So these sources are critical, and one of the things that we might need to do, as in any research for the resource tracking exercise, is to try to identify whether there are routine information sources that we can tap into than jump into a primary survey at the get-go. I'm talking about, for example, government spending usually gets compiled by the Ministry of Finance, and the Ministry of Finance does this on annual basis, compiles all expenditures, including the spending on health by the government. So that might be a primary source for us to be able to tap into before trying to go and try and capture it from the end users of the funding, such as providers. The second example that I can provide is for companies like insurance companies that are managing resources that are coming to them to process claims. That type of spending can be captured. Usually there is an authority that licenses these insurance companies. For example, for Namibia, just recently that we have completed a health accounts exercise, and we have seen that there is a Namibia Financial Institutions Supervisory Authority, called NAMFISA in short, that compiles all the expenditures or claims that have been settled by the insurance companies. And it also has information on also the premiums that have been collected by these insurance companies, including the medical aid schemes. So it was a primary source, and rather than going after each insurance company, this data compiles it all. Similarly, even though not everybody is aware of them, donors or development partners, when they enter into an agreement in a country, they have a unit that is, the government in most of the countries have a unit that follows up the development partner project. And there are reports that they receive. So probably that might be our primary source to try to capture spending from developer partners. Another source for development partners is, for example, PEPFAR does regularly capture the spending by its implementing partners. So that might be a primary source for us than trying to capture the data using a primary survey. I think one key source that has been raised earlier is the household. When we talk about households, usually there is a regular survey that the statistics bureaus in most of the countries conduct related to estimating the household consumptions and expenditure. Within that, health would be definitely one of the components. To what extent can we tap into that should be the primary area that we need to start with before trying to capture it in any other way. Other sources that we can think of for the employers, we can talk about Chamber of Commerce, usually, or the employer associations have some type of reports that they receive from their members. To what extent it includes the benefits that the employers provide to their employees is different, but that might be nonetheless a starting point for the teams that are embarking on a resource tracking exercise. I know when we talk about resource tracking exercise, although it's heavy on expenditures, to unpack some of the spending, we might need information related to utilization and costing. And those are typically compiled in the HIS of countries, depends on the details available, and any costing studies that are available, we need to make sure that we have them handy as well. So the other components that I talked about, the factors, is related to coordination. I would give you two examples. For example, in Namibia, we have worked with the team, the country team, which completed a resource tracking exercise. That resource tracking exercise compiled information that is needed for the health accounts as well as the NASA. Previously, there were separate exercises that were conducted in the country, but now, looking at the benefits of capturing the information at one go, the team has gone after that in one exercise than separate data collection. Conversely, there was an example from another country whereby there were 3 resource tracking exercises that were conducted at the same time. That means that respondents were getting similar type of information requests for 3 separate exercises at the same time. And you can imagine if you are in the respondent through the fatigue that it would create and the bearing that it will have for the technical team in terms of policy. So this is an example of, and for health it's really, really common, even though outside of these big resource tracking frameworks, there are other small demands that come in for either a monitoring of a specific program that happen within the health sector. And that is really something that needs to be concentrated on or looked at. Stakeholder engagement. This is one of the key things that you have raised, Shipra, and which reminded me is in the first webinar we talked about use. The primary purpose of a health resource tracking exercise is the primary audience is the country team, and it is to inform policy and programs. So that should be at the center. Why that's important is all the time as technicians, me included, we struggle with or we get enticed into collecting the data, a large amount of data. Whatever is available, we need to get it. And one example is for example, we try to capture information on spending for a number of years long gone. Is it really relevant policy? It might have a relevance, but we need to be clear, we're capturing it for a specific purpose and to inform policy and programming. So that is the first thing that we need to do, understand is we need to make sure that what is the policy need. Also, another related factor is there is, on the demand side, there is always, initially you start with a wider demand policy needs, but the data that you have available might not allow you to go that far. So we need to also have that discussion between what is our policy need and what is feasible as well, to make sure that we have a successful exercise and a streamlined exercise. I would, on the second bullet, I have talked about engaging diverse stakeholders. I just got back from a dissemination event in Guyana, whereby the health accounts team finished a resource tracking exercise. This is the first that they have completed. But one of the things that they have highlighted and that's critical was to the success was that they have engaged all the key stakeholders. I'm talking about, in addition to the Ministry of Health, they have included the Bureau of Statistics, they have included the Ministry of Finance, they have included the biggest insurance company, they have included the donors or development partners to be part of the team, as well as their one big referral hospital that has a chunk of the government spending. So they have engaged them into the process, both in the technical team and providing oversight and support. That helps them, remove some of the blockage that they got when it comes time to collect the data, and also giving them guidance overall in terms of through the analysis process as well. So that is really key. The third point is related to the first point that I made. If you don't have a political will, an owner, a champion that is demanding that data within the country, policy within the senior management, the success of the resource tracking exercise or how streamlined it is would be imperial. I give you an example that in one country, the health resource tracking exercise languished for 2 years because there was a change in management, and the new management was not keen on having that as their priority. So if there's no political will, it's really a futile exercise as well.
Thanks, Tesfai, for drawing on HSG's experience to share these really valuable thoughts and strategies with our audience. As a reminder to our audience, if you have questions for Tesfai, you can submit them now or even later in the Q&A window. So we're going to move on to our next panelist now, Mr. Leandre Gouigui, who is going to share with us Benin's experience. Leandre is an economist with more than 9 years of experience in developing public health policies and health financing strategies. He leads the production and institutionalization of health accounts in Benin, and he's also been actively involved in the evaluation of the national health sector strategy. Leandre also heads the division responsible for carrying out studies focused on the management of health sector resources at the Ministry of Health. Leandre is a French speaker, so my colleague Karishma Bhuwani will be helping us translate between English and French today. Leandre and Karishma, thank you for joining us today and welcome. Leandre, could you please start by telling us what are the main strategies that Benin has used to try and make health expenditure tracking exercises more efficient?
Bonjour Léandre. La question était quelles sont les stratégies principales que le Bénin a utilisées afin de rendre des exercices de suivi des dépenses plus efficaces?
Okay. Merci beaucoup à toute l'équipe. Merci pour l'intérêt que vous apportez au travail qui se fait au Bénin. Pour aborder la question, il faut d'abord dire que l'équipe du Bénin a élaboré à ce jour 7 exercices de compte de la santé, dont les 2 derniers sont en cours de finalisation. Globalement, nous avons 3 grandes stratégies. La première, c'est l'utilisation des données primaires. La deuxième, nous avons produit l'utilisation des données secondaires. Et la troisième, c'est celle que nous sommes en train de faire actuellement, c'est l'intégration des données financières au DHS2. Pour le premier, il faut dire que l'équipe des comptes de la santé était bien obligée de faire la collecte à tous les niveaux de la pyramide sanitaire, département, bureau de zone par bureau de zone, ce qui prenait beaucoup de temps. Alors, nous avons pensé à l'utilisation des données secondaires. À cette étape, si nous prenons l'exemple des assurances, et au niveau du ministère de l'économie et des finances, nous avons pu avoir, par exemple, toutes les données globalisées des assurances. Donc, nous n'avons plus besoin d'aller de compagnie d'assurance en compagnie d'assurance. C'est un atout. La troisième stratégie, c'est l'intégration des données au DHS, qui va nous permettre d'accélérer le processus de collecte de données pour l'élaboration des comptes de la santé. Merci.
So, merci, Leon. Leon explained that Benin has completed 7 exercises. They have completed 5 in the process of completing 2. There are 3 strategies that they have used to track health expenditure. The first is primary data collection, the second is secondary data collection, and the third is the integration of financial data into DHIS2. So initially the team collected primary data on health spending, so they would go to each department and each region or zone in the country and collect health spending data. But that was taking a long time, and so they're also using the strategy of secondary data collection now. The example given was about insurance. So for example, instead of going to each insurance company to collect health spending data, this data is compiled at the Ministry of Finance. So the team can get all the data for insurance from the Ministry of Finance. And the third strategy is the integration of financial data into DHIS2, which has meant that it's quicker to compile and track spending.
Leonta, could you please speak in a little more detail about Benin's work in linking DHIS2 with health accounts?
Léandre, pourriez-vous parler un peu plus sur le lien entre le DHIS2 et les comptes nationaux au Bénin?
Ok, d'accord, merci. Pour expliquer, il faut dire que le PNDS, la mise en œuvre du PNDS se fait généralement à travers les plans opérationnels que nous élaborons dans les pays. Et si nous prenons le PNDS en lui-même, il est organisé de façon structurée. Au Bénin, quand nous prenons le premier niveau, c'est les orientations stratégiques qui sont déclinées, d'accord, en objectifs stratégiques, qui eux aussi sont déclinés en axes d'intervention, puis en actions prioritaires. Alors donc, cette logique d'intervention a été structurée, d'accord, a été structurée comme un canevas, et que nous avons maintenant paramétré dans le DHIS. Alors, ce paramétrage qui a été fait dans le DHIS permet d'avoir à chaque niveau un code. D'accord? Et ensuite, maintenant, nous allons collecter tous les plans personnels à tous les niveaux de toutes les structures dans la pyramide sanitaire. Alors, ces plans que nous allons collecter, nous allons les paramétrer maintenant dans le DHS2 de façon à ce que, quand nous prenons une activité, il sera bien logé avec un code unique. D'accord? Et donc, cette base que nous allons créer sera paramétrée dans le DHS. Et ça va, et ensuite, ça donne comme la troisième étape, ça permet, d'accord, de visualiser tout ce qui est planification dans tout le secteur. Après une année de mise en œuvre, il est facile pour nous, lorsque au niveau périphérique, les gens, l'exécution de leur activité est intégrée à la base. Déjà au niveau central, nous avons la possibilité alors de d'exporter cette base-là et d'en faire les revues annuelles que nous faisons, d'accord, le suivi annuel du PNDS, d'accord, que nous allons encore et chaque année, cet exercice sera plus facile parce que les codes étant uniques, il sera facile pour nous de faire le reporting mapping pour répéter. Donc chaque année, nous avons la facilité de répéter les comptes sans aller sur le terrain. Voilà un peu la méthodologie que nous sommes en train d'adapter au Bénin. Merci.
Merci, Léandre. In Benin, the National Strategic Health Plan is implemented through annual operational plans. And in the National Strategic Health Plan, there is a certain classification. So there are strategies, then interventions, and then actions. And so those were all integrated into the DHIS2. And then all the operational plans that feed into that strategic plan were collected, so at all systems, at all levels of the health system. And all the operational plans, they were matched with the classifications in DHIS2. And so by the end, every activity in DHIS2 has a specific code that matches to the operational plan and then back up to the strategic health plan. And so after each year of implementation, the team can use the financial data that's being reported in the DHIS2 in order to monitor implementation of the strategic health plan, but also to produce the health accounts. And Leon mentioned that this makes it very easy because each year, once the activity codes are in DHIS2 and financial data is being reported, those codes can be used every year, so that saves a lot of time.
I suspect that our audience is really excited to hear this this way to improve the efficiency of conducting health accounts exercises. So, Leandra, could you please tell us what steps would other countries need to take if they wanted to try and implement this strategy? And could you also maybe say a few words about the lessons you've learned in this process?
Léandre, que sont les étapes que vous recommanderiez aux autres pays qui voulaient utiliser le même approche? Et pourriez-vous partager quelques leçons apprises pendant ce processus?
OK. Merci, Karishma. Pour les différentes étapes qu'il faut mettre en œuvre pour la réalisation de cet exercice, je peux les regrouper en 5. Premièrement, il faut d'abord l'élaboration de la nomenclature du PNDS. C'est une étape fondamentale pour réussir l'outil. Parce que c'est cette nomenclature qui présente nos statuts, la logique d'intervention de la mise en œuvre du PNDS. Ça, c'est un. Deuxièmement, il faut nécessairement que tous les acteurs du secteur valident cette nomenclature. Tout le monde s'accorde sur cette nomenclature. Et troisièmement, d'accord, il faut collecter tous les plans intégrés, plans de travail annuel de toutes les structures du ministère de la Santé. D'accord. Quatrièmement, cette base, tous ces plans que nous avons collectés, quatrièmement, sera implémenté, d'accord, dans la maquette qui a été déjà paramétrée dans le DHIS pour en faire une base de données unique dans le DHIS2. Et enfin, après la mise en œuvre, après un an d'exécution, d'accord, c'est cette base qui va être utilisée pour faire le suivi de l'évaluation du PNDS, qui va permettre de faire la revue annuelle, d'accord, le rapport de performance, et c'est cette base encore qui va être utilisée pour élaborer les comptes de la santé. Donc voilà 5 étapes qu'il faut parcourir. Et enfin, pour aborder les leçons apprises, il faut dire que cet exercice facilite d'abord l'élaboration des comptes de la santé, en un, d'accord. Deuxièmement, ça réduit le temps d'élaboration des comptes, d'accord. Et enfin, on peut dire ça facilite aussi l'élaboration du PNDS, l'élaboration de la mise en œuvre du PNDS, des revues sectorielles. Et la difficulté qu'on peut avoir, c'est le paramétrage. C'est fondamental. Il faut que les gens arrivent à faire le paramétrage du PNDS dans le DHIS2. Voilà un peu ce que je peux donner comme quelques idées sur les leçons apprises.
Merci, Leon.
Merci. Oui, merci.
So Leon explained 5 steps for creating this link between DHIS2 and health accounts. The first is to develop the nomenclature or the classification of the strategic health plan that reflects the logical flow of implementation. The second is to ensure that all stakeholders agree with this classification. Next, all the operational plans of all the units down to all the facilities have to be collected and matched to the codes in DHIS2. And then over the course of the year, those operational plans are implemented, and then after 1 year, the team uses the data that's been reported through DHIS2 to monitor the implementation of the strategic health plan and the health accounts. In terms of lessons learned, Leandre highlighted that this link has really facilitated the production of health accounts. So it's reduced the time it takes, and it also makes the annual health sector reviews a lot easier. One factor that he said was very important, but that takes some effort is getting the classification right at the beginning.
Thank you, Karishma, and thank you, Leandre, for taking the time to present so clearly your approach to streamlining production in Benin. I think it'll be very useful and interesting for our audience. So just as a reminder to the audience, if you have questions for Leandre, please feel free to submit them in the Q&A window now. We're working on compiling questions for the Q&A session later on. So Leandre shared with us Benin's approach to making expenditure tracking more efficient and less resource intensive over time. I thought I'd share with you just a few more quick examples from other countries. In Burkina Faso, they've actually been using a similar approach for a number of years, the only difference being that they don't use the DHIS2 platform in Burkina. In Barbados, they recently decided that they were going to do a high-level update of health spending using mostly secondary data in between the years that the country can afford to do a health accounts exercise. In Bolivia, where resources are quite limited, they managed to do a health accounts exercise every year by only doing an analysis of the financing classifications and health accounts, such as revenue sources and schemes, and not classifying expenditures all the way down to providers and disease. And they do this using mostly secondary data sources and with almost no primary data collection. So those are just a few examples that might be interesting for you all to hear and think about. We're going to shift gears a little bit now and move from country strategies and experiences to a more global perspective from the World Health Organization. We have with us today Dr. Hafsa Touré. Hafsa is a health economist with 12 years of experience. She works with the resource tracking subunit of the WHO's health financing team, where she's in charge of streamlining and coordinating expenditure tracking work in African countries. Prior to the WHO, Hafsa worked with the Bordeaux School of Public Health in France and with PricewaterhouseCoopers in Côte d'Ivoire, where she gained wide experience in costing and in external financing of health systems in Africa. Hafsa, thank you for joining us today and welcome. Could you please start by sharing with us an overview of the WHO's efforts that are related to streamlining the production of health expenditure data?
Yeah, thank you, Shipra. And thanks for the opportunity given to me to present WHO's work on this interesting topic. So, as our audience may already know, one of WHO's Department of Health System Governance and Financing mandates is to maintain the global health expenditure database, the main source of information for country and global health financing experts. And to help get that right, WHO helps countries streamlining, the production of good quality data by, first of all, releasing technical notes and guidance implementation materials that they can refer to. And that, I think, enables more reliable cross-country comparisons. And the team also provides direct technical support and organize regularly regional training, peer learning workshops, and we also maintain a community of practice people, and from where countries can share experience, they can exchange ideas, and on, let's say, how best to tackle common challenges they face. In parallel, WHO also worked on making available specifically designed IT tools which participated in making, this huge amount of data manageable. That's how I can describe our efforts in that area.
Could you go into a little more detail, Hafsa, on the WHO's technical support to countries and how this helps them with making the production of expenditure data more efficient?
Yeah, sure. So in terms of technical support per se, first, WHO is the leading agency coordinating the production of health account data in the ground. And we are able to do that thanks to a roster of certified consultants that countries, wanting to starting their health accounts for the first time can tap from. So any country interested in starting the health account can, being assigned one certified consultant. So this group of consultants, have been trained and they are regularly assessed, in terms of the content and the quality of their interventions. And by saying that, I want to stress here the importance of, ensuring that, the data production reaches a certain level of quality. And being taught right, I think, is key here. And as much as possible, we try to encourage staff-to-staff collaboration. So we enroll the well-experienced government technicians, and we get them assigned to the neighboring countries. And this, we think, is the only way for gradual capacity building and knowledge transfer in the ground. So in the end, the more experienced people we will have, I think the smoother the production process will be. We also organize annual regional meetings exactly for that same reason, so that people can meet and interact with their counterparts from the other countries, and getting back home, they can implement what they have learned during those regional meetings.
Thanks, Hafsa. So WHO has been leading the development of tools used for health accounts. Could you share with us maybe how these tools can help countries in terms of streamlining production?
Yes, sure. So as I said earlier, so WHO has developed a set of health account tools. So the health account production tool at one hand, and the health account analysis tool on the other. And at the moment, these two stand separately for country to use, but they stand separately. These are two different tools. And I have to say these have been proven to be of great contribution. Since country teams, they have moved out from Excel-based exercises, that were prone to human errors, and they were very labor-intensive. So if I may say, we are now saving time and money producing the health account data thanks to those tools. And also, the production tool itself, constitutes an institutional memory, which is very appreciative in contexts where human resource turnover can be very high. So in the tool, the team taking over from the previous team will find in all of the documentation if the process has been done properly, the year before. And besides, the fact that the tool ensures consistency, since each expenditure line, needs to be mapped to all classifications in the study, and the existence of, the repeat mapping feature, that is, repeat common budget structure from one year to the other, and the already existing tables, graphs, reports, all of this, in my view, constitutes great help in reducing the time to produce the health accounts and ensuring, again, good enough quality information in the end.
Thanks, Hafsa, for taking the time to share with us these valuable strategies and tools that I'm sure have been really helpful to countries in producing health expenditure estimates. I think we're going to turn to our audience now to see what kind of questions you all have around streamlining production of expenditure data in your country and in your work. Please feel free to ask questions that are general in nature or even specific questions in your country context. Don't forget to submit your questions in the Q&A window and indicate if your question is for a particular panelist. Our first question is for Tesfai Ashagari from HFG. Tesfai, could you please tell the audience what can a health accounts team do if they don't have recent household spending data to include in their health expenditure estimate?
Thank you, Shipra. So I think a recent example from Indonesia comes to mind, whereby the team didn't have a recent household data, but as part of the Bureau of Statistics, the statistics agency has been, as part of its estimation of the national accounts, which is trying to measure the size of the economy, has been regularly updating the private consumption component. Within that, one of the key components that they have is estimating the out-of-pocket spending as well for health. So the team, the health accounts team on the ground, has been working with this statistics team to try to make sure that there is a consistent estimate of the out-of-pocket spending that is in line with the size, the measurements that they have used for the national accounts. The national accounts tries to capture information from both the supply side, which is the providers, and they try to capture the information on the demand side from the household surveys. So that has been one area that has been used. Of course, this is a primary source that I think the teams need to tap into. For the long to medium term, there are regular surveys that are being conducted, such as the consumption expenditure survey that I talked about, or DHS, which might include the household module. If the second option is, if it doesn't match with the year, obviously if we are doing a regular resource tracking exercise every year, the household survey doesn't get done every year. So another way of estimation is trying to using the medical inflation and population growth as an interim estimate, to use it for the interim estimate for the household spending.
Thanks, Tesfai. It looks like we have another question in for Hafsa from the WHO. Hafsa, you've shared with the audience key features of the tools used to produce health accounts estimates. And I know through our conversation you mentioned that the tool will be revised soon. So the question is, how will the WHO's planned revisions to the tools assist in streamlining production?
Yeah, so thank you, Shipra. So to complement what I've said, beyond the existing thing, what we are trying to do as a next step is, first of all, to merge the production and the analysis tool, so that it's better understood that production and use of the data should work together. So country teams shouldn't only, being concerned of producing for the sake of producing, but also try to analyze and understand the use of that data, which is valuable data. So that's the first thing. So in the future, we'll have, let's say, a main tool, including all of the features together. And as a second point, we are also trying to increase the interoperability of the tool. So by this, what I'm trying to say is we were receiving complaints from people saying that this is kind of something blocked, and beyond, being able to extract the data through, cross tables, there's not much that people can do. So in the future, we hope that people can extract the raw data And that data can be shared and analyzed using statistical software of interest. So anyone wanting to use data or anything else for further and deeper analysis, they will be free to do so. So these are the key, I would say, key things that will happen in the near future. And I think maybe this is the good opportunity for me to say that we are welcoming feedback and specific requests from our users. If any, this is now the moment, so they are free to send us anything they may think of. Yeah, that's what I can say answering your question, Shipra.
Thank you, Hafsa. That's really helpful, and hopefully you will get some feedback from our audience members who are listening in today. I think we'll choose a question now for our third panelist, Leandra from Benin. Leandra, could you please tell us how you handle shared costs, such as salaries, in your linking of strategic plan activities in DHIS2 with health accounts?
Léandre, il y avait une question pour vous. Comment est-ce que vous gérez les dépenses agrégées, par exemple les salaires, quand vous utilisez le DHIS2 pour produire les comptes?
Allô?
Oui.
Allô? Tu peux reprendre la question, s'il te plaît?
Oui. Comment est-ce que vous gérez les dépenses agrégées, par exemple les salaires, quand vous utilisez le DHIS2 pour produire les comptes nationaux?
Ah, d'accord, merci beaucoup. Je pense que c'est pas compliqué, c'est toujours ce qu'on a toujours l'habitude de faire. En réalité, dans la base que nous avons codifiée, même les salaires auront un code, d'accord? Si nous prenons par exemple un hôpital où les salaires sont payés, il y a deux sources pour le salaire. Il y a les ressources de l'hôpital et le salaire que l'État paye au personnel. Et nous, on aura dans la base le montant agrégé, d'accord, de ce que l'hôpital paye. Lorsque nous allons exporter la base pour faire les comptes de la santé, il suffira pour nous d'utiliser les clés de répartition que nous avons l'habitude d'utiliser pour éclater cette dépense agrégée-là de façon à avoir, d'accord, de façon spécifique ce qui est payé pour tel spécialiste, ce qui est payé pour tel autre spécialiste. Donc, c'est les clés de répartition que nous avons l'habitude d'utiliser, que nous allons utiliser pour déterminer, d'accord, pour désagréger alors les dépenses qui sont agrégées.
Merci. So in the DHIS2, salaries have a specific code as well. So for example, at the hospital level, they're able to see spending on salaries by the hospital itself and spending on salaries by the government, by the ministry. And so once they have this data on salaries from the DHIS2, the health accounts team uses distribution keys to disaggregate salaries by disease or other classifications. And so this is done outside of the DHIS2, the distribution key application.
Thanks, Leandra and Karishma. We have another question for Tisfai. The question is, if secondary data does not have the information that is needed for health expenditure estimation, what are the next steps a team can take to make sure that they get the information they need for their exercise?
Okay. Thank you. So I see it in two phases. One is the first phase is really related to what do we do in the short term. Again, this is, of course, if the data is not available anywhere, then we need to resort to a primary source. But when we talk about primary source, always the one thing that I have seen helpful is we need to understand the reporting systems of the respective institutions that we are trying to get information from and fashion our surveys or instruments accordingly. We don't want the respondents to be our analysts, because the analysts the analysis is the job of the team that's conducting the exercise. We need to get, however, the maximum detailed information that they have in the way they report it regularly as a starting point. So that's one thing that needs to be done in the short term. We need to go after a primary survey, but starting with an instrument that can easily align to the information system that they have in the shift it is in their regular report. But I see resource tracking as a regular exercise, and so for the medium to long term, the issues would be easier because then there needs to be some ongoing conversation with these usual sources to try to make sure that the information system can be able to capture those types of information that we need. Leanne's example related to making sure that the DHIS is already capturing the information that's needed for the resource tracking exercise for the government is one example. The Namibia one that I raised earlier on related to insurance, on top of what the supervisory authority provides, also the country team is on the ground, is working with the Private Medical Aid Scheme Association to modify their reporting on the claims so that it has the necessary details required and they don't have to go back to help unpack some of the expenditures that were not unpacked in the supervisory authority's data. So that's another example that we can go on. Donor and NGOs, I think we have talked about earlier on, but we can also have a discussion with the Ministry of Finance, which follows and monitors the programs by development partners, to include some critical components that we need for our regular resource tracking exercise as well. Similarly, NGOs, those that are being licensed through either the Ministry of Health or the Planning Commission, that would be a source to tap into to try to make sure that we can be able to embed components that are required for the resource tracking exercise.
Thanks, Tefai, for addressing that question. It looks like we have another question for Leandra. Leandra, what was the reaction of the district-level health officials after they used DHIS2, for example, to see their spending data tracked by annual work plan activities?
Léandre, il y avait une question pour vous. Les équipes santé des districts, quelle était leur réaction après avoir utilisé le DHIS2 comme vous avez expliqué? Par exemple, leur réaction de voir leurs dépenses suivies par activité du BNDES.
Ah, bon, je comprends. En réalité, nous ne sommes pas encore à cette phase, d'accord? Et en réalité, il faut que nous finissions le paramétrage des plans opérationnels que nous allons collecter. Et c'est après ça que nous irons vers les gens, les acteurs du niveau périphérique pour pouvoir travailler avec eux. Et c'est après la mise en œuvre, d'accord, de leur activité qu'eux vont intervenir. Pour l'instant, nous ne sommes pas encore à cette étape.
Okay, d'accord. So Benin is not yet at this stage. At the moment, they're still matching the operational plans with the codes in DHIS2, so they haven't yet been able to show the data back to the districts themselves.
Thanks, Leandra and Karishma. We have another question for Tesfaye. Tesfaye, what role can academia play in institutionalizing health accounts at both national and regional levels?
Okay. Thank you very much. So I think this is a good question. I will see it again from two angles. One is always this resource tracking exercise as at least the common frameworks that are available can be taught to as part of this pre-service training so that people are familiar with it and the students can be able to help either by providing the data or making sure that when they are out of school, they can be able to provide that. One example that I can provide you, I think there are 2 countries that have done that. There is Kenya, whereby they have embedded resource tracking as part of the health economics and public health curriculum. Similarly, in Tanzania, we had that situation whereby the team in the University of Dar es Salaam has embedded that resource tracking as part of their curriculum as well. The other component is, I think, in both Zambia and Indonesia, the production of the exercise is done through with the support of the universities in both countries. For Zambia, we're talking about the University of Zambia that is supporting the process, and Indonesia, the University of Indonesia team is supporting the technical production of the exercise. Another role that academia plays is, given that its use is the critical point for the exercise, academia plays a critical role in shaping the analysis in such a way that it's readily available for policy uptake as well. And this is a critical point to keep.
Thanks, Chefbai. We have, I think, time for one more question. A quick question for Hafsa from WHO. Hafsa, one of our audience members is asking, when is the next annual regional meeting for health accounts?
Is this the global meeting, right? So the global meeting is happening in Geneva the week of September the 70th.
Thanks, Hafsa.
You're welcome.
Thanks to our audience for your really thoughtful and insightful questions. Unfortunately, it looks like we're out of time, so we won't be able to take any more questions. If you're interested in additional information on this subject and on expenditure tracking in general, this slide has some resources. You'll see our last 2 webinars, and as I mentioned before, this webinar will also be on the HFT website soon. We do hope that you found this webinar to be informative and also useful in the work that you do in your countries. I think we all recognize that detailed estimates of health expenditure are really important in terms of forming a strong evidence base for policy formulation and planning decisions, and we hope that the information you heard today will help you all think about ways in which you can make regular expenditure tracking a reality in your country. So I want to thank again our panelists and you, our audience. Just a quick note that once you close the webinar window, a survey will pop up in your browser. If you don't mind taking a moment to complete the survey, it'll help inform future webinars. Thanks and goodbye.